So now that you understand where the fear came from, let's talk about what the actual risks are, because everything has risks. Going to the mailbox to get your mail has risks. You could get hit by a car. Flying on an airplane has risks. Every medical decision has pros and cons. So it's important, though, to understand exactly what those are and have a conversation about how they affect you. The risks are breast cancer, heart disease, blood clots, and then, of course, the risk of doing nothing. So let's dive into those things next. One of the challenges when you're looking at evaluating the literature, when they're talking about risks, is something that is totally exaggerated, and it is the difference between absolute risk and relative risk. Mark Twain famously said, there's lies, damn lies, and statistics. What does that mean? So you can manipulate data and say things in a certain way that sounds very extravagant and headline worthy, but in actual numbers, the risk may be very small. So I want to review that with you where I have the data and let that sink in for you so that when you have these conversations, you're not just blindsided by, oh yeah, but they said this relative risk was blankety blank and therefore don't do it. Relative risk is a percentage increase, whereas absolute risk is the number of women per blank. Like usually it's per 10,000 user cases. If the risk increases from one woman in 10,000 users to two women in 10,000 users, that's double the risk. That's 100% risk increase, but it's only one extra woman. So that's where this relative risk thing is very confusing and it's sensationalized. The North American Menopause Society, which we call NAMS, came out with a position statement, and a lot of the information that I'll be sharing with you today is regarding the risk is from that. It was in 2022, and they came out with a hormone therapy position statement. Let's talk about the breast cancer risk. There was a study called the E3N cohort study, which came out in 2008, and it looked at over 80,000 women. And they followed these women for 8 years, and they found that it was the progestin component. And again, listen to the word I'm using, progestin. There's no hormone called progestin, but it's the progesterone-like hormone, which was medroxyprogesterone acetate, because they found that the estrogen-only arm, even though it wasn't bioidentical estrogen, it was conjugated equine estrogens in Premarin, but OBGYNs have always been taught that if a woman has had a hysterectomy, she doesn't need the progestin component anymore. So there was an arm in the study that got estrogen only. There was no increased risk in breast cancer on the estrogen-only arm, but there was in the estrogen plus the progestin. That implies that it was the progestin that caused the risk. It's pretty basic. That, again, didn't make the evening news. One of the things that the NAMS study did was it calculated absolute risk from some of these numbers. So the absolute risk of oral synthetic combined hormone replacement therapy was 9 additional cancers per 10,000 women years during the active treatment. That wasn't a large increase at all. So if we were to look at that with a little different denominator, fewer than 1 additional breast cancer case per 1,000 women users each year. And yet women were told don't take hormones because they cause breast cancer. Now, what NAMS also does is it puts it into context regarding other risk factors, which are lifestyle mediated. For instance, and I'm looking at the study here, so forgive me for not looking at the camera. The risk is slightly greater than observed with 1 glass of wine, less than with 2 daily glasses of wine, and similar to the risk of low physical activity. Yet, women aren't really told much about those other lifestyle things that they can do to decrease their risk. So what if you did all the healthy things and did all the lifestyle things that you could and took hormones? Then you got all the benefits from hormones and the other things that would decrease your breast cancer risk. These studies are just so hard to interpret, and it makes it hard to know the right thing to do. But what I'm really just trying to portray to you is that you can't just look at headlines. You have to have a conversation with someone who is willing to ask the hard questions and listen to your questions and give you honest answers. Let's move on to risk number 2, heart disease. And here there's a paradox. because we know that premenopausally, women have a much lower incidence of heart disease than men. And then the number starts to parallel and increase to be equal to men after menopause. And what's the difference? Estrogen decline. We know that estrogen increases blood vessel elasticity. That's a good thing. So why is it hard to determine the heart disease risk? Well, I'm going to go back to what I said earlier, and that is that number one, if they already had heart disease, it's going to look like it's not preventing. Number two, they were using oral estrogen. Oral estrogen increases inflammatory mediators, which increase your risk of heart attack and stroke. It's a no-brainer. Don't use oral estrogen. The theoretic risk, though, is that if you already have heart disease, maybe it's slowly progressing, and then you start hormone replacement therapy, even if it's not oral, could that be the inciting event to lead to a major cardiac event, a heart attack? It's theoretical, but the thought process, I think, stems from the fact that because estrogen increases blood vessel elasticity, if you have pre-existing plaque and now you increase elasticity, the plaque could dislodge and lead to a clot, which leads to the heart attack or stroke. Though we can't do that blanket statement that anybody over the age of 60 shouldn't be on it. There's other things, and we'll get to that in a later segment of what we can do to evaluate someone's heart disease risk and get it minimized before we start them on hormones, AKA clean up your rusty locks. The hormone locksmith, let's give you the right keys, but let's make sure your locks aren't rusty, which are your cells, so that your hormones actually work. Okay, risk number 3, blood clots, venous thromboembolism and blood clots. This is not an issue in my practice because we don't use oral estrogen. This was well studied, and it should be a non-issue at all anymore, that transdermal, meaning patch, cream, or pellet, because it's inserted below the skin and absorbed into the fat in the bloodstream. So non-oral estrogen does not increase your risk of heart attack and stroke or venous thromboembolism, period. End of discussion. Don't use oral estrogen. And what about now? Let's talk about the risk of doing nothing. Women are living 30 to 40 years after menopause. You want to live that in a hormone deficient state? As a gynecologist, I've helped so many women through this transition and seen what happens to them over time if they're not using hormones. Over and over again, in the years that I would be caring for women, they go through menopause. And at this time, many of them were afraid to take hormones. And I hadn't learned to think outside the box enough to encourage it. So they would come in initially and we would talk about how they were doing. And of course, I would ask them about sexual function. And maybe for the first year, it wasn't an issue. Yeah, no problem. By the next year, when I saw them for their annual exam, yeah, we got to use a lubrication. I never had to use a lubrication before, but we're okay. We're using KY or Astrogel or something like that. And then by 3 to 4 years later, help. I'm not able to have sex anymore. I feel like I'm ripping. It's drier. I'm getting vaginal irritation. I'm getting bladder infections. I'm leaking urine. There are estrogen receptors in the bladder, in the vagina, and it increases elasticity, improves epithelial function to decrease bladder infections. Estrogen receptors are all over your body. And if you're living 30 to 40 years in a hormone deficient state, you're going to have issues. We know that women who take hormone replacement therapy have a lower incidence of dementia than women who don't. You tell me when you don't need your brain anymore, and I'll tell you when you can stop taking your hormones. It's not a number. Brain function is important. We need our brain. Your brain is your fountain of youth, where your memories are, where your balance is, where your control, where your response time is. All that's related to brain health. And hormone replacement therapy is fertilizer for your brain cells. Another risk of not doing anything, colon cancer is higher in non-hormone replacement therapy users than in hormone replacement therapy users. Bone health, skin health, gut health, your microbiome changes with estrogen deficiency. Estrogen is everywhere. I don't think women should be forced to live 30 to 40 years in a hormone deficiency state. I encourage my patients to use hormone replacement therapy once we've made sure that we're doing it safely. Use the right hormones. Make sure that the levels are balanced and that you actually follow the levels. Make sure that you're metabolizing the hormones in a safe fashion. You do those 3 things, You can get all the benefits of hormones for a long time, absolutely minimize the risks, and live long, well. That's the goal. Live long, well.